We've got hot flashes, we've got night sweats, we've got sleep disturbances, new onset depression, anxiety, musculoskeletal symptoms, vaginal dryness, degenerative urinary syndrome, menopause. What if you have all of those symptoms and the one thing you didn't think was possible was a pregnancy? And boom, what happens next? We're going to talk about that today. I'm going to get into a patient that I saw in the office last week. So let's get at it. Hi everyone, welcome back to my channel, GynoGirl TV. I am Dr. Sameena Rahman. I am a gynecologist, board certified, that has a specialty and an expertise in sexual medicine and menopause management. I have my own private practice in downtown Chicago, and I've just recently joined hands with Ms. Medicine, which is a national network of concierge physicians and clinicians that specialize in women's health, and I am their first gynecologist. They have mainly internist and primary care, and so I'm working alongside Dr. Lisa Larkin. I'm super excited. My new practice name is the GYN and Sexual Medicine Collective. So please come over and check it out and like and subscribe to my channel. I'm going to be telling you about my book that's coming out soon, and so stay tuned to that. But please, like I said, like and subscribe to my channel. I want to talk to you guys about a patient that I saw recently in my office. We talked about all the symptoms that we have in perimenopause and the ups and downs and the real chaotic period of time that we have going on, not only with our hormones, but our life in general, right? So I saw a patient and she has 3 kids and 48, married for 20 years, having all the symptoms that we think about. Her cycles are irregular. They've been irregular for a long time. She had fertility issues in her 30s. She basically was having, some hot flashes, night sweats, sleep disturbance, weight gain, new onset anxiety, sexual complaints, low libido, but was still having sex with her partner because she felt like she had to. We talk about how women just feel like sometimes they have to do it, even if they don't have the drive to do it. But she came to see me and she was having a little bit more fatigue than what I would have expected. And she told me that she's having unprotected sex. And that was a big red flag for me. I was like, oh, okay. A lot of fatigue, a lot of breast tenderness. We can get both of those in perimenopause. But I said, you know what, let's do a pregnancy test. I just want to make sure. And she was like, okay. So I did the pregnancy test and it came back positive, and she almost passed out. So it wasn't something she expected or wanted or thought that could happen. So I thought this is a perfect opportunity for me to review that when you think your baby making years are over, they sometimes cannot be, or can reoccur, or can lead to miscarriages. A lot of women who get pregnant after the age of 40 do have more miscarriages. That being said, she, is thinking about what she wants to do. So that's up to her. But, she did talk to me about the fact that she did not use contraception because of her previous fertility concerns or fertility issues that she's had. What I wanted to talk about is how you can still get pregnant in perimenopause, and we need to still have some protection on board. You have to remember that we're born with about 1 to 2 million eggs, and by the time we hit age 30, we might have 125,000. And then, the closer we get to 40, we have maybe 25,000. So it goes down really in a very crazy way as the years go by. And so I always say, until you ovulate that last egg, you could still get pregnant. So we have to be aware of that. So, and in fact, 48% of all unintended pregnancies happen between the age of 40 and 45, okay? So just let that sink in for a minute. Almost half of all unintended pregnancies happen between the ages of 40 and 45. Not to mention the fact that a lot of my patients who are in this midlife period of time have new partners, and they might be divorced or widowed or seeking new partners. And a lot of them not only don't use birth control, they don't use protection. So then we're seeing this rise in gonorrhea, chlamydia, and other sexually transmitted infections. My point is, we have to have a birth control plan. What happens in perimenopause and why it's so crazy is, you might have heard Mary Claire Haver speak about what she refers to as the zone of chaos. We all know that this is a chaotic period of time in your life, with maybe kids and careers or not careers, or parents or divorces or deaths, all the things. So there's chaos and stress that you're experiencing, and then there's chaos that's happening to you physiologically. And so there are months that might go by where you might not ovulate, and then all of a sudden your brain is like, hey, what's up? and then it triggers you to almost super ovulate. So we have these luteal out of phase cycles. We call them loop cycles. You might get a surge of estrogen all of a sudden, and that's why you get breast tenderness and headaches and all these things. And so you have this whole period of time, as you can see here, this zone of chaos, that people have this erratic ups and downs with their estrogen and really a deficiency of progesterone from across the board. And that's the cause of all these symptoms. So what are you to do about it? I have a lot of patients that come to me in perimenopause seeking help for their mental health concerns, for their systemic symptoms they're having, sexual concerns, all of that. But we have to remember that we always need to know if you're having sex with a man, we got to know what your birth control is. A lot of my patients, spouses or significant others, have had vasectomy. So that's really, I think, like the best thing that has happened for a lot of them, because they're not worried about that aspect. But if not, let's talk about some of the options that we have. Of course, there are condoms and there's barrier methods, and I have a lot of patients that are going back to those, and that's perfectly fine. And if you're with a new partner, you should definitely use a condom. One of the best methods that I use with some of my patients, because it gives me not only bleeding control, right? A lot of women in midlife develop fibroids, or they have these, really what we call anovulatory cycles, where they have very heavy flow after months of no flow. So if you have a lot of bleeding after months of no bleeding, you can get a very heavy flow. And so you think about some of the women who talk about having to wear diapers or, leaking through their underwear. None of that is normal. Sometimes fibroids are the cause of it. 80% of women have fibroids. They may not always be symptomatic. We'll talk about that in another video. There's endometriosis, and then the endometriosis that kind of occurs in the muscle of the uterus called adenomyosis, causes very heavy periods and cramps. There's endometrial polyps. There are a lot of other reasons that people can have irregular periods or really heavy flow. There's precancerous lesions, there's cancer. All of that has to be examined and evaluated. But say this is all from anovulation, sometimes even with fibroids. What can you do to control the bleeding, but also give you protection in those periods of time that we know we need them? I love the Mirena IUD for that. Mirena IUD has levonorgestrel, which is a type of progestin, at a high enough rate that it causes a thinning of the lining of the uterus. People don't bleed from it. And then they have a lot of great success with controlling their bleeding, and then less than 1% pregnancy risk for it. In fact, I had a patient recently who was 51 still, and we've been following her FSH, or follicle stimulating hormone, because she has an IUD and she doesn't menstruate. So we're not sure when she's going to hit the menopause because she doesn't menstruate. So we don't have that 12 months without the period thing that we look at. But, her FSH was still in like a regular range over 2 to 3 months. So I thought, you could still ovulate. And so at 52, she had another IUD placed, which is not unheard of, to be honest. Because she was like, the thought of a pregnancy for me is very appalling at this point, because she couldn't manage it. It wasn't something that was in her equation. This is a great form of contraception with less than 1% pregnancy rate associated with it. I use it for young patients. I use it for patients with endometriosis, with fibroids. I use it for perimenopausal patients and menopausal patients also, because it gives you that endometrial protection, but also a reduction in bleeding. And so we do that for a lot of our patients. If you have checked out my IUD videos, I use a lot of pain control for my patients. They're not left in the dark when it comes to their pain. And so you can do a local anesthetic. You can prep the cervix ahead of time. You can give IV sedation. I use Pronox in my office. I use a lot of different things, Xanax before you come in. There are things that you can do to make it an experience that will not give you nightmares, that can be not necessarily enjoyable, but at least pain-free. And so that is something you should demand as an aside, that you should demand pain control with your procedures. And if someone is not giving you the pain control that you need, find a new doctor or clinician. Anyway, side note, that's a Mirena IUD. You can use some birth control pills, like the birth control pill that has estradiol, which is E4. It's more of a plant-based estrogen. It gives you birth control as well as can regulate your cycles, as can a low-dose estrogen pill. There are vaginal contraceptions like NuvaRing or Annovera. You can see them here. You can use them every month, or you can try to group them for 3 months at a time. There is gives you like a steady state of hormones, which are great options for a lot of patients. So, and then of course there's a copper IUD that has no hormones, and then there's barrier methods like we talked about. So we have to have a plan in place. I wouldn't necessarily recommend the copper IUD for that in perimenopause, because can get heavier and more painful periods, but some people are very adamant about not having hormones. I have to say that by the time they hit their midlife and they need hormones, we always switch them to a Mirena IUD. And so that's something to consider. You want to continue, you can continue the birth control pill up until 55. What I do for some patients is at 50, some people take it continuously because a lot of patients will get great relief of perimenopausal symptoms when they can control their hormones. And so what I do is have patients maybe come off of them at 50 or 51, see what happens with their cycles, and then see if they have the other symptoms, and then treat them with some body identical hormones. And so that's always an option as well. So we have those options to use the birth control pills. And again, if you don't want to use birth control pills because you've had bad experiences in the past, which is a lot of my patients, and some of them need the birth control pills because it helps not only for birth control, but for pain with their cycle. But if you're not in that category of people and you want to try something different, you can use condoms and barrier methods. And there's something called Phexxi, which is a spermicide that you can use before sex as well. And so we have options. We should use them because this surprise, I'm pregnant at 48, is no fun for people who did not want that or are not able to. So then there are other things they have to deal with at that point. And so this is my friendly reminder to you that until your menopause is confirmed, until you have those 12 months without a cycle, perimenopause is full of changes, but an unintended pregnancy should not be one of them. You need to get some contraceptive counseling in there. I think that, if you are someone who is in a heterosexual relationship, that should be on your mind. So for those of you listening, if you are in perimenopause and you experience a lot of change and you were not sure that you needed birth control and this happened to you, please comment and we can get a conversation going. But don't forget to like and subscribe to my channel. This is my PSA for you that, we still need contraception until we can confirm that you're in menopause. Even that one final egg can do it to you. It only takes one, right? And so if you are lucky or unlucky, depending on how you look at it. All right, that's it for today, guys. I'm Dr. Sameena Rahman. Please like and subscribe to my channel. I'm here to educate so you can advocate for yourself. So hopefully you learned a little something and you'll keep in mind the use of birth control is important in perimenopause. And so we got to think of all the options. Of course, you know what I didn't tell you about is tubal ligation, which we don't ligate tubes anymore. We remove tubes because we know that tubes are the source of most ovarian cancer. So at this point, we do salpingectomies, which is a removal of the tubes. So a lot of patients will refer or decide that they want to make sure that they can't get pregnant. Even in the younger population, they're now getting this done. Tubal ligations or removal of the tube is another option through a minimally invasive surgery, which a lot of people don't want to get. But you know what? If you have a history of ovarian cancer in your family, you may want to consider it as an option. That's a whole different discussion. I will actually do a video on some of the genetic predispositions to cancer and what you can do about it and genetic screening at a different date. I'll try to close again. I'm Dr. Sameena Rahman. I'm here to educate so you can advocate. Please join me for my next episode and please like and subscribe to my channel. Thanks, guys.